All right, so let's put together kind of everything that we've been talking about to go over some of the disorders of complement. Probably the least high yield of the four on here is going to be this early complement deficiency. It's just like the name says, it's early, right? So it's in the first few stages. So you have some deficiency. It could be C1, C2, C3, C4. It's pretty nonspecific. But in general, if you had a deficiency of these early complement factors, the patients are more likely to have respiratory and sinus infections in particular. Okay, and there's an increased risk of developing lupus. Now remember, lupus, we tend to see low levels of complement, particularly the early complement in the setting of lupus. And you can kind of make a case, well, is that because you have more complement activation? Maybe you have an autoimmune hemolytic anemia, thrombocytopenia, etc. Is it kind of the chicken or the egg, which came first? But in general, there is an association here, so just keep that in mind. Like I said, probably the least high yield of the four, but it's good to have it in here just for inclusion's sake. What I would focus on that's much more high yield is the terminal complement deficiency. And the biggest thing that you have to take away from this is that these patients are at increased risk of Neisseria infections. And there's some repercussions of this where this can turn into kind of a more complicated question stem that I'll talk about in a second. But in general, what you really want to know, what you really want to take away from this is if for whatever reason there is a deficiency of C5 to C9, right? Particularly, we're talking about C5b to C9, right? That's going to form that membrane attack complex that we talked about. And that's going to be very much associated with, like we said, perforating pathogen membranes, particularly effective, like we said, against gram-negative bacteria. And the big one that we always talk about, again, being Neisseria. Okay, and we'll talk about this in a little bit more detail in just a minute. Before we do that, though, let's jump into talking about the C1 esterase inhibitor deficiency. So again, the general concept here is, right, if I have some microbe, right, this is going to be my pathogen, right? And then I tag this thing with an antibody. And then remember my FC portion here, if it's IgG or if it's IgM, let's just say it's IgG. This FC portion, particularly close to the hinge region, I can have complement formation. So I can have a C1 complex come here, and then I can take C4 and C2 and essentially convert these to C4a, C4b, and C2a, C2b. And I know the B's are going to stay, and these can come together to form my C3 convertase, which is going to be used to take C3 and then cleave C3, right, to C3a and C3b. But the point here is that for, if I have C1 esterase inhibitor around, that can inhibit this C1 from acting, right? It's just like the name says, C1 inhibitor. Okay, so it can inhibit the C4 and C2 from going down this pathway. And this is used to regulate, overactivation of complement and that type of thing. Now, in some people, though, they have a deficiency of this C1 esterase inhibitor. And the presentation they have, one of the things you'll see is that their C4 levels are very low. And again, you can make sense of this, right? So if for whatever reason you didn't have this C1 esterase inhibitor, let's do this in another color. Let's just say you didn't have the C1 esterase inhibitor, okay? So you didn't have it or you had really low levels of it. What would happen is it wouldn't be able to inhibit the C1 component, right? And so if it wouldn't be able to inhibit the C1 component, this C1 component might go kind of overactive, right? Because it's not going to get regulated at all. So you're going to have more and more of this C4 and C2 getting converted to their subcomponent, C4a, C4b, right? So what's going to happen to your C4 levels in the blood? They're going to go down, right? Same thing with the C2 levels. So you might have very low C4 levels, and that's typically one of the tests that come up when they're asking questions about C1 esterase inhibitor deficiency in general. There's a lot of stuff written here about bradykinin, so let's talk about that. Now, we said earlier that bradykinin in general, when we were talking earlier in this playlist, we said that this is very much involved with things like vasodilation, right? Vasodilation. And we also said it was very much involved with the pain response. When we feel pain, that has to do with those high levels of bradykinin when we have inflammation. And, bradykinin comes from this high molecular weight kininogen. Okay, I'm just going to write it HMWK, sometimes written as kininogen, but we'll just write it as high molecular weight kininogen can form bradykinin. And what causes high molecular weight kininogen to form bradykinin? That would be kallikrein. So kallikrein will help stimulate the conversion of high molecular weight kininogen to bradykinin, and then bradykinin causing vasodilation and pain. So you can imagine if you have an inflammatory response, you're going to have higher levels of kallikrein, so you get more bradykinin around. That's the concept. We need regulators, right? We need some kind of regulator of this process. And so the regulator here is your C1 inhibitor, C1 esterase inhibitor. Actually comes in and it says not only does it inhibit C1 in the complement cascade, but it also inhibits kallikrein, again, keeping things in check. right? So things don't get out of control. And that's what the C1 esterase inhibitor is doing. Now, again, going back to the point I just had, if for whatever reason a patient had a deficiency of the C1 esterase inhibitor, now it can't inhibit kallikrein. So what happens? Well, now kallikrein can go unregulated, right? It can go unregulated and it can just stimulate this process to a very high degree. And so what you're going to get? You're going to get very high levels of bradykinin. You're going to get a lot of vasodilation, right? And this can also cause vascular permeability to increase, and you can end up with edema. Okay, so you can end up with increases in vascular permeability, and you can end up with edema. And these patients can also have a lot of pain because of these really high levels of bradykinin in the setting of a C1 esterase inhibitor deficiency. So these patients, typically, this will be autosomal dominant. Okay, remember, we always try and remember the autosomal dominant diseases, the X-linked recessive and X-linked dominance, and then anything that doesn't fall in those categories, that's going to be autosomal recessive. Okay, that's kind of my way of organizing it. And again, we have increased levels of kallikrein. We already talked about that. The kallikrein is going to basically go unregulated, and that's going to lead to increases in bradykinin. Now, the presentation typically, and there's more detail on this, we're just going over the high yield stuff here. Typically, these patients will have recurring angioedema. They might have facial edema. They might have abdominal edema where they have abdominal pain and nausea from edema that's happening there, or even edema in the extremities. Okay, the concern here is we don't want these patients to get laryngeal edema, where we start to close off the airway. Okay, so this is going to kind of present almost looking like this patient is, potentially going into anaphylaxis, or this patient had some allergen exposure. But one thing that's different when you're talking about C1 esterase inhibitor deficiency from something like a type 1 hypersensitivity is that in this situation, there's really no urticaria. Okay, especially in a board question. There's no urticaria. So that's one way that you can try to tease out some type of type 1 hypersensitivity leading to anaphylaxis versus a C1 esterase inhibitor deficiency, because they're treated differently, right? Because if I have a patient that has anaphylaxis, I might be thinking epinephrine. If I have a patient that has C1 esterase inhibitor deficiency, I can try and get these patients C1 esterase inhibitor because that's what they're missing. That's going to slow this pathway down. If I give them concentrated C1 inhibitor, that will inhibit this kallikrein and we can get the bradykinin levels under control. So they're treated differently. So it's important to distinguish them. One thing they'll say is that the patient recently received an ACE inhibitor or was started on an ACE inhibitor. So we talked a little bit in the cardiology section about this, about how the ACE enzyme, it has a few different functions in the RAS cascade. But one thing that it does is it actually inhibits bradykinin. Okay, so if we had a patient that had an underlying C1 esterase inhibitor deficiency and we started them on an ACE inhibitor recently, okay, so if we just started them on an ACE inhibitor and they already have low levels of C1 esterase inhibitor, look what's going to happen. If I put somebody on an ACE inhibitor, I'm going to inhibit this enzyme, right? And so now if I inhibit this enzyme, I'm not able to regulate my bradykinin. So not only will my kallikrein be, stimulating bradykinin, so there's more and more bradykinin being produced potentially, but I can't even inhibit the bradykinin with the ACE enzyme to try and keep things under control. So it's kind of like double trouble here because I have an ACE inhibitor that's inhibiting one thing that's regulating bradykinin, and then I don't have my inhibitor to control kallikrein, so I have even more bradykinin. And so that's typically how this will come up. So these patients should avoid ACE inhibitors, but a lot of times in a board question, that's how it's presented. They were started on an ACE inhibitor for high blood pressure or whatever, and now they're presenting a few days later, potentially with new facial edema or abdominal pain, recurrent abdominal pain with new edema, etc. Okay, so that's usually going to be the trigger. The trigger can also be trauma, stress, right? There are a lot of different things, but that's one classic way that this comes up. All right, PNH, paroxysmal nocturnal hemoglobinuria. So this is classically going to be a hemolytic anemia. You can have effects on some of the other cell lines, but essentially what's happening here, if I just draw in a red blood cell here, I'm going to have certain proteins on this red blood cell. We're going to call them GPI. And so these are going to be membrane-bound glycerol, phosphatidylinositol proteins. Okay, so GPI proteins. And these proteins are going to be things like CD55, right? We already talked about what CD55 does. This is your decay accelerating factor. It's going to inhibit the C3 convertase that we talked about when we went through the complement cascade in the last video. Okay, you're also going to have other GPI proteins on here, like CD59, which is going to inhibit the membrane attack complex, right? And that's going to be the membrane inhibitor of reactive lysis. Okay, so we already talked about those. So these are going to be on the cell surface of my red blood cell. Okay, so this is my red blood cell. So in a way, I kind of want these things on my red blood cell because I don't want my red blood cell to get destroyed by complement that's floating by. I don't want complement to get activated on my red blood cells. Now, if for whatever reason though, I didn't have these proteins, okay, let's just say I didn't have these proteins on the surface of my cell. Well, if I didn't have them here, it might be more likely that I potentially could have complement activated on my red blood cell. And that complement cascade that eventually leads to a membrane attack complex forming, right, would destroy my red blood cell. And that's essentially what PNH is. So it's complement destruction of red blood cells due to loss of these GPI proteins. Specifically, CD55, right, we talked about that. That's a decay accelerating factor, and CD59. Okay, so those are the two that you really want to associate here with this paroxysmal nocturnal hemoglobinuria. We're inhibiting the inhibitor again, or we don't have the inhibitor, so to speak. So we have overactivation on our own cells. It doesn't just have to be on red blood cells. It could be on white blood cells. It could be on platelets. You could have a pancytopenia with this potentially. So again, in general, and you'll see this a lot when you're talking about hemolytic anemias, you see this in lupus, these patients will be very fatigued, right? They're going to have much lower oxygen carrying capacity in general. Systemically, they're going to have pallor, intermittent jaundice. Where's the jaundice coming from? We're going to have all of these red blood cells, right? We're going to have bilirubin that's being released, that's causing some of this jaundice. And then we'll have some hemoglobinuria, potentially with kidney injury, because of all of the red blood cell destruction. Now, the very classic thing, though, that you'll sometimes see with PNH is going to be this venous thrombus in atypical locations. So the idea here is as you're destroying these red blood cells, like we just said, you're going to have breakdown that eventually leads to high levels of bilirubin in the blood, but you're also going to have hemoglobin. And hemoglobin can cause oxidative stresses onto the endothelial walls. So this hemoglobin can exert oxidative stresses, right? Oxidative stresses, oxidative radicals can start to damage some of the walls here, particularly in areas where there's a little bit more venous stasis, okay, where there's blood not necessarily moving as fast, and that's going to be more on the venous side. And this can eventually lead to clots forming, right? We can have venous thrombus that form. And again, the classic thing is you typically aren't going to see venous thrombus in the hepatic veins, for example, right? The hepatic veins, renal veins, or the cerebral veins, right? So you're going to start to see kind of these very unique locations, not the typical, deep venous thrombus in the leg, right? These are going to be atypical locations in board questions as kind of a call out. So if you see patients that have intermittent jaundice, pallor, fatigue, hemoglobinuria, particularly hemoglobinuria that's worse in the morning, very classic for PNH, okay? And why I say worse in the morning is because if a patient is, gets up to have their first void in the morning, the urine's typically going to be more concentrated because they were sleeping and they weren't consuming fluids. So a more concentrated urine plus the fact that you're spilling hemoglobin, that's going to tend to be the darkest urine, where you're going to have very dark red appearing urine, okay? Very classic for PNH, dark urine in the morning. When you have this venous thrombus in atypical locations, particularly in the hepatic veins, that's sometimes referred to as Budd-Chiari syndrome. We'll go into way more detail on this when we get to the GI section, but when you start to block off the blood leaving the liver, right? All that blood is going to start to sit in the liver. You're going to end up with this congested liver that sometimes starts to form what's called a nutmeg liver, okay? And we'll get into more detail with that, but eventually that leads to a liver failure. And you're going to get a backup of a lot of that venous blood. You're going to get things like ascites, peripheral edema. One thing you won't get usually is going to be JVD, because the backup on the venous side is proximal to the jugular veins, right? If you had JVD, you'd be thinking more about something like CHF, okay, which we went through a whole bunch of detail on this in the cardiology section too, but you just have to think about this anatomically speaking, right? The hepatic veins are going to drain eventually into the inferior vena cava. And the blockage, if you had a hepatic vein thrombus or Budd-Chiari syndrome, would be before the hepatic veins reach the inferior vena cava. So you wouldn't expect, for all those reasons, jugular venous distension, okay? But you would expect things like ascites, peripheral edema, for that reason. Okay, now if you're going to diagnose this, the Coombs test is negative. And I don't want to get too off track and go down this rabbit hole just yet, but we will talk in great detail about the Coombs test. This has more to do with antibodies on the surface of these cells. Again, the point here is not that we have antibodies that are destroying the cells. The point here is that we're missing our own inhibitory, regulators of complement on our cells. All right, and the last thing here is there are certain drugs that you do want to be familiar with. Now, step one isn't as big on testing medications, but this drug in particular, the eculizumab, is an anti-C5 antibody. Okay, and so the idea here is if I'm destroying my own cells, right? If I'm destroying my own cells because I don't have my CD59 and my CD55 to regulate things, to inhibit complement from attacking my cells, I can try to attack the complement that's attacking my cells, okay? As crazy as that sounds. So if I had an anti-C5 antibody, okay, so here's some antibody, and let's just say, right, that I have, let's go back to my red, let's clean this up and go back to this red blood cell here. So here's my red blood cell again. It doesn't have the CD55 or 59 on it. And let's just say that for whatever reason, right, complement starts to get activated here. And again, it's probably going to start with C1 complex or C1-like complex. That's eventually going to lead to the formation of a C3 convertase. And eventually, it might have some C5 that binds, right, when I get to my C5 convertase. What these anti-C5 antibodies do is, as this is happening, right, as this is kind of going through the complement cascade, these antibodies can then bind to that C5, right? So here's some C5. It can bind to this and destroy it so that we never really get to a point where I form C5b and then form my membrane attack complex. I can't get to that next step to actually destroy the red blood cell, all right? And that's what this drug is doing. It's a monoclonal antibody, right, that ends in MOB, eculizumab. And there's also another one on here, not as high yield. But the point is if I use this medication, right, which may work very well, the issue is that if I can't form membrane attack complexes in this patient anymore because I'm inhibiting C5, what would that predispose this patient to? That would predispose them to Neisseria infections, because I essentially am giving this patient a terminal complement deficiency so I don't destroy their red blood cells, right? That's essentially what we're doing. And so because of that, now these patients are at increased risks of Neisseria infections. So if you give a patient eculizumab, you have to know that this patient is going to be at increased risk. So you're going to have to make sure they're vaccinated from Neisseria. And in some cases, they might even be on prophylactic antibiotics to prevent certain infections, particularly, again, Neisseria being the big one. And that's something where you have to, that would be a great board question because you're integrating so many components of your knowledge here. So that's the way you have to kind of think at some of these multi-level questions, especially when you go on to step 2, when you have to have a little bit more wider of a knowledge base in terms of what's going on.